This is one of the most practically actionable predictions in this entire landscape, and it is also one of the most underappreciated. The concept of chronopharmacology, the timing of drug administration to align with the body's circadian biology, does not require new molecules, new delivery systems, or new clinical infrastructure. It requires a change in prescribing culture based on evidence that, in many areas of medicine, already exists and is already being ignored. The circadian system governs nearly every physiological process in the human body. Hormone secretion, immune activation, cellular repair, drug metabolism, tumor cell division rates all follow predictable 24-hour rhythms. The liver enzymes responsible for metabolizing most drugs are themselves circadian, meaning that the same drug administered at different times of day will be metabolized at different rates, producing different plasma concentrations and different durations of action. This is not speculative. This is biochemistry. The oncology data is perhaps the most striking. Studies of chronochemotherapy, administering chemotherapy drugs at specific circadian phases, when cancer cells are most vulnerable and when healthy cells have the most active DNA repair mechanisms, show that drugs can be 50% more effective and significantly less toxic when timing is optimized. 50% more effective without changing the drug, without changing the dose, without changing the patient. Just by asking when instead of assuming the answer is always the same. In cardiology, a landmark study demonstrated that blood pressure medication taken at bedtime rather than in the morning was associated with dramatically better cardiovascular outcomes, including a significant reduction in heart attack and stroke risk compared to morning dosing. The mechanism is coherent. Blood pressure follows a circadian pattern, reaching its highest values in the early morning hours when cardiovascular events cluster. Ensuring peak drug coverage aligns with peak vascular risk is straightforward once you ask the question. The barriers to adoption are instructive. Physicians are not trained to think chronobiologically. Drug prescribing information rarely includes circadian timing recommendations because clinical trials almost never randomize by time of administration. Patients are not counseled on timing because prescribers don't consider it. The entire system is, in this respect, operating on a one-dimensional understanding of pharmacology when a two-dimensional approach, what and when, is both available and evidentially superior. As continuous biomarker monitoring matures and AI systems begin to incorporate circadian data into clinical recommendations, personalized chronopharmacology becomes technically feasible. Individual chronotype variation, night owls versus morning types, affects the timing of physiological peaks, meaning population-level timing recommendations may need individual adjustment. But beginning with the evidence that already exists, for drugs where circadian timing effects are well documented, and simply changing prescribing defaults is an opportunity available now. The cost of implementation is essentially zero. The resistance is almost entirely cultural.